Hi, my name is Patricia McGough. I'm a researcher in public health, and we're going to look at maternal mortality in Afghanistan. Who's affected and where? It's women and girls who are pregnant and located in places of poverty, rural areas, and deeply conservative areas in Afghanistan. Socio-cultural issues, gender inequality, and lack of access to healthcare are causing high rates of maternal mortality in Afghanistan. Some of the inequalities are social cultural norms in Afghanistan. For instance, traditionally women and girls are forced into marriage at very young ages, and without access to family planning programs, they frequently have babies with no spacing in between, and these young girls are more likely than women to experience complications that could lead to death during childbirth. Also, clinics, hospitals, and healthcare can be inaccessible to pregnant women and girls because women are restricted from leaving the house without a male relative or in their presence, and access to healthcare is limited when it is culturally taboo for a woman to be treated by a male healthcare provider. Some of the inequalities or sociocultural norms contribute to the limited access of healthcare, such as women needed to be treated by female healthcare providers. However, most women and girls are restricted from getting an education, which then the restrictions on education prevent women from becoming healthcare providers. Many pregnant women in Afghanistan are living in poor rural areas, and traveling to clinics or hospitals can be very difficult. Even if women are able to reach these clinics and hospitals, they might choose not to go for reasons of suspicion or trust issues when it comes to medical intervention. It's very common for pregnant women to go to untrained members of the community to help with the delivery of their baby. Also, Afghanistan is greatly affected by decades of conflict, and this contributes to a weak economy, which limits the clinics and hospitals and access to education. The social ecological model on the individual level, the factors that hinder the health of this population on an individual level is the lack of knowledge about family planning and reproductive health. This is particularly harmful to young girls who are having babies, since young girls their bodies aren't ready to be having babies. And this causes great risk of complications during childbirth. The factors that could help is knowledge, and the way to gain this knowledge is through education, equal rights, and access to family planning programs. On an interpersonal level, their families lack the knowledge of healthcare and complications that could occur during pregnancy and childbirth. The family most likely will not understand the importance of recognizing health risks during childbirth. The factor that could help would be to inform husbands and family members about maternal health, because they are usually the ones making decisions for the women and girls. The most helpful and possibly life-saving factor would be teaching them about conditions that would require the assistance of trained health providers. The factor that hinders this population on an organizational level is the lack of access to schools and healthcare services. This is influenced by poverty and sociocultural factors. The factor that could help would be increase access to education by having the government fund more schools and ways to learn and allow girls to learn. Increased access to education will help increase access to healthcare services if part of the funded education is to teach women the skills to become midwives. The factor that hinders this population on a community level are the socio-cultural norms. In low and middle income countries, cultural taboos, like the ones I previously mentioned, they limit the access to healthcare. Also, it's common for pregnant women to go to untrained members of the community, and most of the time these deliveries are performed with a lack of proper sanitation, which puts them at risk. The factors that could help reduce the social-cultural norms that restrict women and girls would be gender equality, but this is something that will take a long time. Therefore, the thing that would help the most would be access to education. The factor that hinders this population on a policy level is the range of human rights violations, particularly child marriage. The factors that could help would be stricter laws against child marriage. If they change the legal age of marriage for females to at least 18 years instead of 16 years, and if they eliminate consent to marriage by a 15-year-old girl's father or contempt court would be extremely helpful. A lot of in poverty and the cultural practices can lead families to use child engagements, exchange of marriage and bride price to gain money, goods, or to solve communal disputes. So the change in marriage law would be very helpful, and it would have to be enforced. Also, access to education would help lower the amount of child marriages. There are 3 proposed interventions. The first one is on a community level, distributing vitamins, supplements, and medication. Instead of traveling to a physician, there would be community health workers who would deliver the vitamins, supplements, or medications to the homes of the pregnant women and girls. This would help prevent conditions that contribute to the risk of maternal mortality. There's evidence that has shown that calcium supplements and some medications have prevented hypertension. This intervention would have the measurable goal to reduce maternal mortality rate by at least 3% the first year of the intervention and at least 5% the continuing years. The intervention will be deemed successful if the initial goal is reached or exceeded. Both the initial and the post-intervention data would be collected by surveying, going in the community and surveying, and then it would be compared to the data that UNICEF or World Health Organization provides on the rates of maternal mortality. The challenges that could be seen with this intervention is, since this affects very rural areas, data integrity is an important aspect. There could be pregnant women who are inaccessible to the delivery system, since it's such rural locations. And there might also be women who were involved who later, post-intervention, you can't access to get the post-intervention data that you would need. So monitoring the progress as often as possible throughout the intervention could help reduce this risk. The second intervention would be education. We saw in Bangladesh that the government invested in educating girls and training more birth attendants. This investment was a success. Since the start of this investment in 1991 through 2004, Bangladesh halved the number of women dying in childbirth. The education helped women know what to do during pregnancy and post-pregnancy to protect herself and her baby. Also, education empowers women to have say over their bodies and ensure that they plan their families properly and suspend marriage until their bodies are ready and they are not being sexually violated. Adapting this intervention in Afghanistan would be beneficial since a lot of the conditions for women are the same as Bangladesh. The goal would be to increase the percentage of girls that have access to education. And the outcome could take years, like it did in Bangladesh, to see how it's influencing maternal mortality. So the initial success will be determined by the increased percentage of girls and women enrolled in school, and fewer girls getting married and having babies before their bodies are ready, and increased access to skilled healthcare providers, and this would show success. And again, the baseline data and the post data would be collected in the community with surveys, and it would be compared to the maternal mortality rates reported by UNICEF or World Health Organization. The challenges for the education intervention would be that it could take a long time, since Bangladesh took 13 years to see the success. So the data would have to be collected with great integrity for a long period of time, so monitoring the process throughout this time would help to maintain the goals of the intervention. The third intervention is having male involvement in family planning, reproductive health, and maternal health. Since men make decisions in the government, community, and family in Afghanistan, it's important for them to have education on these things. And there's actually a school for husbands in Nigeria that's been making a difference. They formed this program as a way to inform men about gender equality, respected men within the community that have shown interest. They learn at family planning, reproductive health, maternal health, and these men bring this information back to the community, and the other men in the community respect what they have to say and listen to what they have to say. This could also help with the strong religious beliefs in this area. There's another schooling where Islamic teachings and the interpretation of the texts are discussed for the religious beliefs of being suspicious of maternal care. Men are taught that it's okay for women to see male doctors because it's okay when males have medical expertise, and that in the texts the Prophet Muhammad mentioned using preventative measures for procreation. And since men dominate social structures in Afghanistan, gaining the support of men to ally for women in maternal care could make all the difference. The goal is to increase the percentage of men who understand and respect family planning, reproductive health, and maternal health. The success of the intervention will show if pregnant women are seeing healthcare providers, and more women and girls are spacing out their pregnancy by using birth control, and if education for women and girls is more widely supported in the community. Again, the baseline and the post-intervention data will be in the community surveyed. The challenge with this is data integrity. Since this data will contain the opinions of men and women and girls in the community, there could be biases. Therefore, creating a survey that is more objective than subjective might help reduce bias. Evaluation efforts could collaborate among various interventions by including community as much as possible in the process. Gaining the trust of the people in the community to participate during the planning, implementation, and evaluation of interventions could allow for collaborative efforts and improved results. Members of the community will be more likely to want and actively help the intervention succeed. In the logic model, the inputs are mostly the same for all three. You need funding and also educators and community health workers. And the activities, outputs, and outcomes all come to the impact of reducing maternal mortality. Most interventions are available, they're easy to implement, and known to the health community. These interventions can become part of the system even in the poorest countries. The most important aspect of successful intervention to reduce maternal mortality is whether or not the government and community leaders make it a priority.